Okay, I'm recording now.
Okay, good afternoon, everyone. My name is Gerard Phillies from the University of the Western Cape. We've invited Barbara Brandt today to do a webinar for us, and I'm just going to give her an opportunity to give us a little bit of background or an introduction to her talk. And then I think we can go directly into your presentation, Barbara. Okay. And once you're done, I will invite colleagues for comments and questions. So a warm welcome to everyone, and I hope that you will enjoy this afternoon session.
Okay, well, thank you. Can you put those slides up? Thank you for inviting me here today to share one of the topics that we're working on in the National Center for Interprofessional Practice and Education. And first of all, I'm hearing feedback. I'm wondering if who's ever on could mute their lines. Yeah, thank you. I'm going to share with you today a presentation that I gave in New Zealand at Altogether Better Health. And I think that's why I've been invited to share this with you today. And just a little bit about me. I am a faculty member and an administrator at the University of Minnesota in the US. I was the Associate Vice President for Education for 15 years, was brought to the university to lead strategically implementation of interprofessional practice and education at the university. In 2012, there was a RFP, a call for proposals by the federal government to designate one center, one national center in the United States to coordinate both interprofessional education and collaborative practice and spread the word. The University of Minnesota competed for that designation, and we were selected and have been leading this effort nationally. So it was a time of intense work, healthcare reform in the United States. We have 4 private funders also that have funded this particular center. And so we have a very broad reach in the US and know a lot about what's going on. There are 130 centers and offices of IPE now in the United States. Healthcare systems come to us and the like. So sharing you that of the breadth of experience that we're gaining here in the US. So the title of my presentation this afternoon for you is Bringing Workforce Planning and Interprofessional Practice and Education Together Around Patients and Populations and Not Professions. And my collaborator, who I literally have talked to every month for the last 4 years, is Erin Frere. And she directs at the University of North Carolina, Chapel Hill, the Carolina Health Workforce Resource Center. And she and Erin and I have written this paper for the themed issue on workforce and IPE, and it's soon to be published in the Journal of Interprofessional Care. So what I'll be talking to you about today is actually going to be a paper that I think will be coming out fairly soon. So this is, I'm not going to read on the slide, but Erin and I have substantial funding, both in private foundations and from the federal government. And the one thing we want to say is that what we talk about, and we are constantly collaborating on presentations, in no way, shape, or form is official policy or position or endorsement of our funders. So we ended up collaborating and giving this presentation together because of massive change in the care delivery system in the United States. For a variety of reasons, the system is broke. It is broken in many ways, both from cost, financially, quality of care, and the like. And so again, I alluded to the fact that she and I share our learning because she works in workforce planning and policy. She's the number cruncher that tries to predict how many physicians we need, how many pharmacists, how many nurses, and the like. And what she will tell you is that we've had it wrong for 40 years. These kinds of projections are typically done in silos. And so there'll be these proclamations that'll come out about, oh, we have a workforce shortage in physicians, and then new medical schools open up, which I know is happening now in England. And so we discovered a common belief that behaving in the same way in both health professions, education, and practice will have significant negative consequences on population health and costs, and frankly, for our health professions graduates. And so we hit the road together and talk about the fact that workforce planners and IPE educators need to come together to tackle these issues together. It's a very uncommon alliance. Typically, we don't talk to each other, but this collaboration that we've struck has been very productive we believe. And so this is what I'm going to talk about in a nutshell. I've already talked to you about our new collaboration. I'm going to talk to you about New Zealand as a mental model for redesigning workforce, practice, and education around patients and not professions. Erin spent 6 months in New Zealand on a sabbatical. And so we tell people that you might not think that a small country as New Zealand is not applicable, but they're dealing directly with cost, quality, technology, and they're focused on consumer pressures. And we are in the United States, without what's called Obamacare or not, are experiencing the same pressure points. And so we talk to people about, we literally here use the term old school thinking or traditional thinking in contrast to new school, new thinking approaches. And again, underscore that we believe the way forward in this uncommon alliance will serve both of our fields well. A little bit about the National Center and our philosophy and belief. We actually, and I know my colleagues in the interprofessional world don't totally agree with me, but the National Center actually uses the term interprofessional practice and education, or the new IPE. And we do that because we believe that you can't have one without the other. So often when you say interprofessional education, people think, oh, that's what happens in the walls of universities. When we try to make the point, and the concept of the nexus is that they must come together. And so we believe that this nexus concept is a process of redesigning both healthcare education and healthcare delivery simultaneously together to be better integrated and more interprofessional. And we have projects all over the United States where we're actually collecting outcomes data on this new redesign. And so we are working towards this unified system of practice and education to achieve what's called the quadruple aim. And the quadruple aim in the United States is just our marching orders right now. It used to be the triple aim, which is the simultaneous pursuit of improving patient experience of care, improving the health of populations. And in the United States, we very much need to be reducing the per capita cost of healthcare. I know that in other countries, which advocacy of wanting more funding and more resourcing, that seems a little out of kilter. But in actuality, this managing cost of care so we can stretch our resources, we find resonates in many environments. But because of the massive changes in the US delivery system, we are having significant burnout of our health professionals. So the quadruple aim also opens up a concern about our current clinicians and health professionals, their own health, well-being, and resiliency. So as we redesign the system, as we bring in team-based care, we are really focused on what is the impact of to the current working clinicians. Just throwing this in because those of you that follow us, we had a study group in the Institute of Medicine. It's now the National Academy of Medicine, And a publication came out in 2015 on measuring the impact of IPE to patient and health outcomes. And this is a model that is becoming a very significant model that we work with in the National Center. I won't belabor it right now, but we actually draw upon the work, Hugh Barr's work with colleagues in the UK around the modified Kirkpatrick models. We're doing a lot of teaching conceptually and linking it to health and systems outcomes. So a little bit about in the United States, and I do know elsewhere, because we do work internationally, that workforce planning approaches are not fit for purpose to meet the future challenges. In the US, traditionally, we start from the professional, not the population health or service professions. We count noses by professions. So we know how many physicians there are, how many nurses there are, but it's a very limited definition of the workforce. And it's used to feed stakeholder agenda of that we need more. Just a little bit about that. When you say we have a physician shortage, you'll hear the physician groups say we need more funding, we need more medical schools and the like. In pharmacy, we actually had a pharmacist shortage, but now we're producing way too many. And our numbers of schools in the US doubled in the last 10 years, and many of those now are actually at risk of closing. And so it is not used to redesign workforce and workflows that I'll talk about in care delivery models to meet patient needs. It's, oh, we need more physicians, we need more nurses. And what you'll hear me talk about is New Zealand has actually flipped that conversation. So on my side of the house in the conversation, the field of IPE is not new. It's 50 years or more old, but it's always lived on the margins. And the perception is that IPE's long history has led to limited change. And I tell people that students are not going to change the care delivery system because of enthusiasm or their passion for IPE. Obviously, we're training really well students that know how to collaborate, they're enthusiastic about it, but at least in the United States, our healthcare delivery system needs to change, and it's really the 18 million current clinicians and workers that need to be retrained and retooled. And I believe firmly that interprofessional education has a lot to give to this system redesign. The next piece is we're always asked about, so tell me what the outcomes is of all of this work. And my colleague John Gilbert at the University of British Columbia has a saying that you can't evaluate what you haven't done. And frankly, a lot of the studies and evaluation has been on individual programs. It's been an evaluative, not standardized, but there is evidence that is growing. And one of the best studies that I use all the time is the Best Evidence Medical Education Review of 2016. There is definitely nuggets in there that I use every day to help people understand what we are learning about interprofessional practice and education. So a little bit about New Zealand and what would the Kiwis do as Erin learned from her sabbatical in New Zealand. So they have been leading an effort from around 2010, but it really started to take traction around 2014. They saw their aging population, they saw population health needs, but their budgets only were increasing by 40%. So they took a look at their current workforce and decided it is not sustainable, it is less productive than in the past. They have too many workers not practicing anywhere near the top of their scope of practice or abilities. They're not meeting quality outcomes or measures, poorly distributed against need. So in the United States, we're getting a disparity of access to healthcare professionals in the rural areas, rural and underserved areas, not enough professionals in the right places, and that a large proportion of the workforce is nearing retirement. And in their estimation, when they did the analysis, their primary care, mental health services, oral health, and rehabilitation systems not up to scratch. And I would say this is totally consistent with what we're experiencing in the United States. So this is a website. It's a wonderful website to poke around and to see what they're doing. They have a 20-year plan. It's very highly engaged. They started a strategic effort in which clinicians, citizens, lots of engagement around this workforce redesign. So they developed workforce service forecasts. And so they started with the question, what are the patient's needs for care? And how can health professions' roles, regulation, education, and practice be redesigned to meet those needs? Really importantly, the big question is, we need to change regulation, we need to know what it is, and we need to do it. So the goal is to envision a workforce needed to meet doubling of demand with 15%, I thought it was 40% increase in funding while maintaining or improving patient satisfaction. So the approach encourages out-of-the-box thinking about what care pathways and workforce should be instead of retrofitting care delivery models to meet the competencies and roles of the existing workforce. So these workforce service forecasts are in these areas. So they have both health service areas and they have population health areas. So I'll give you a couple of examples to give you a flavor of what they're thinking. New Zealand is the #1 country in the world for melanoma, incidence of melanoma per population. So in this workforce service forecast, they did not say, oh yes, we need to start training more dermatologists. They took a look at what could be the workflow that they can get to better outcomes with particularly their melanoma dermatological cases. And in that case, they decided that there could be a triage where a dermatology technician or worker or professional could actually be frontline diagnosers and to save the real thought and the real deep knowledge needs for the dermatologist. And I would say, since thinking through this type of rethinking, we now have technology that's actually doing diagnoses better in certain areas, and melanoma happens to be one of them, than actually physicians. That is by data. Another example is gastroenterology. In that workforce service forecast, they projected that nurses could actually do endoscopies. And this one is very much starting to happen, because when I was in New Zealand, I actually talked to a number of people, and indeed they are actually infusing nurses into the workforce workflow pipeline. So again, that just gives you a flavor of the kind of design that they're looking at. And again, who's the right worker? Who needs to be retrained? What's the type of teams that need to be put together and rethink health outcomes? So it transforms workforce and service delivery from the ground up rather than top down. It looks at what are ideal patient pathways by service areas, and then identifies education, regulation, and practice changes that needs to be made. And this is Erin, but she says, make it personal. How should we care for Aunt Susie with dementia? What would that look like? And I actually could go on and on about this particular topic, because I just dealt with my father for the last 2.5 years, and he recently died in memory care. The captain of his team was a nurse practitioner, and that team looked very, very different than the traditional care delivery model. And so then it engages a coalition of the willing and the able, I would say, to overcome professional resistance and a guild mentality. Now, I also have to say, when I was in New Zealand, I did talk to people. It's not, we're not holding hands and going merrily into the future happily. There's some blips. There's some people wondering, why am I getting this task? But again, I see that as such an opportunity for those of us who are interprofessional educators to really step in and to help with new strategies with training. So the common themes included is increase the supply of health professionals along generalists, diffuse expertise from acute to outpatient community-based settings, particularly for mental health, rehabilitation, and geriatrics, and then modify education and regulation to allow task shifting between health professionals, expanded roles for the existing workforce, and I gave you the example of advanced trained nurses to perform endoscopies. Better integrate health and community-based workforce to address social determinants of health. This is happening in the United States. The profession that's really starting to get a notice is social work here in the United States. But I will tell you that social workers also need support in thinking through the redesign of their role in the delivery system in the United States and address the training needs of unlicensed health professionals. In the United States, we have medical assistants now are taking responsibilities in a new and different way in clinical settings. You have community health workers in the US now that are demonstrating incredible outcomes, particularly in churches. And one example is lowering blood pressure rates, develop care coordination competencies, and incorporating technology into workflows. That's from New Zealand, but I can tell you with healthcare reform in the United States, many of these are already happening also. So in the US, in healthcare, with all the healthcare reform, we're seeing let 1,000 flowers bloom. So hospitals and health systems are striving for the AAA. There's a lot of experimentation, but again, less attention is being paid to aligning workforce and education, and a lack of attention to workforce may be the reason why some of our goals for outcomes and payment models are not showing the expected outcomes that we want. I would say what's happening in the United States now is we've got national competencies for interprofessional collaborative practice, and there's a tremendous amount of experimentation, but rather than 1,000 flowers bloom, we actually have 50,000 flowers bloom. Lots of dynamics are going on. So our collaboration I've gone through is also this opening new dialogues and thinking. So one of the things I want to take you back to is that, and Hugh, I've had many conversations with John Gilbert about this, and Maddie Schmidt for that matter, is that the renewed interest in team-based models of care is not a new concept. When you go back to John McCreary's seminal paper in Canada and understand the context, he was anticipating the really expanded thinking of the team. And also in that paper, it talks about addressing workforce shortages, particularly physician shortages. So a lot of the same issues when IPE was being born are very similar to the challenges today. If you go to, in the United States, to the seminal Institute of Medicine report on educating for the health team and really scratch under the surface, out pops their vision at the time of redesigning the workforce also. And actually talks about, in the last part of this presentation, is that we face in the next decade a national challenge to redeploy the functions of health professions in new ways, and extending the roles of some, perhaps eliminating others of the health professions, but more closely meshing the functions of each than ever before. So this concept of overlapping abilities, we call it plasticity of scopes of practice, actually was the vision quite a number of years ago. So now I'm going to take you through what will be in the paper, and as soon as I can get it to you, I will be more than happy to share it to you. is really helping people reframe from a focus in 6 different areas. So reframing our mental model or thinking from old school to new school. So the first one is from a focus of shortages to addressing the demand capacity mismatch, which I've laid out to you. Old school thinking is, will we have enough nurses, doctors, and insert any other health professions in the future? So again, oh, we've got a shortage of this. We need a new school, a new program. We need to increase the supply. To new school thinking is, how can we more effectively and efficiently deploy the workforce already employed in the healthcare system on interprofessional teams? In the United States, that's 18 million clinicians and workers. So shortage or no shortage? And what is shortage of what? Workers, skills, or training? And so people in interprofessional education, ears need to perk up. If we're thinking about a workforce shortage of workers, the prevailing narrative focuses on shortages, but many, not all shortages could be addressed by reallocating tasks among providers. And particularly when we have a maldistribution, we need to take this into consideration. A shortage is of teams. We need to empower teams of licensed and unlicensed providers to reallocate workflows and redesign as I've described. Or is there a shortage of needed skills? So workers with the right skills and training are integral to the ability of these new models of care to constrain costs in the United States and to improve care. Or this is let's perk our ears up for educators. Is there a shortage of training? There's a lot of enthusiasm, particularly in the United States, for new models of care, but they're limited understanding of implications of education. So even when I look at the New Zealand example, there's a disconnect between this workforce redesign that's going on and the interprofessional educators who could bring new skills to the table. So second reframe is from a focus on provider type to recognizing what we call the plasticity of provider roles. So the old school assumes professions and specialties have fixed and unique scopes of practice. New school recognizes that plasticity of real world practice where professions and specialties have overlapping and dynamic scopes of practice. I'll give you an example from the United States. Remarkably, nationally, midwives and OBGYN, obstetrics and gynecology, are working incredibly well together. They have come together nationally and taken a look at their scopes of practice, their competencies, where they overlap, and where they are distinct. We need that in the United States. We have places in the United States, in many states, where there is no access to midwifery or gynecology, obstetrics and gynecology. Women are having to drive 100 miles to have their babies delivered in safe care. So coming together of those two professions and saying, we're going to work together, we know we need to do better, it's just been remarkable. So old school thinking assumes that professions and specialties have fixed and unique scopes of practice. New school thinking recognizes the plasticity of real world practice and those overlapping scopes of practice. So again, workforce is highly flexible. I've described the plasticity. So instead of retrofitting care models to the existing competencies of the workforce, is again, what are the patient's needs for services and how might we help health professions' roles be redesigned to meet those needs? And again, in the United States, this is what's emerging. Many, many, many new roles are emerging, but the workforce planning is not taking that into account. Reframe 3 is from a focus on workforce planning to professions for workforce planning for patients, people, families, and communities. And I've already described this. Old school thinking is silo-based. New school thinking is planning for those services based upon interprofessional teams. So the point here is all this dynamic change and rethinking and reconfiguration about teams. For those of us who are educators, we've been out of the conversation, even though that's the metaphor in the United States for coming out of the hockey is where the puck is headed. So reframe number 4 is from a primary focus of IPE on students in the pipeline to be collaboration ready to concurrently retooling and retraining the existing workforce. So this is where my friends in IPE get a little edgy with me, but I have actually gone through and reread a lot of our literature, and the predominant language and interpreted outside of the field particularly is that this is about classrooms. This is about preparing students to go out and change the world, be collaboration ready. And even the 2010 World Health Organization refers to students. We know that we want to expand that thinking, but externally, that is how it's interpreted. So, and frankly, I will say in the United States, probably 90% of IPE right now is focused on that classroom. And if you go to the McCreary document, that's where the emphasis is came from in the 60s also. So again, old school thinking is that it's primary competency-based curriculum for pre-licensure and foundational education to be collaborative ready. And new school thinking is that we actually need new models of continuing professional development and interprofessional clinical learning environments to support that retooling of the current workers already in the system for new models of care at the same time that we're preparing the future workforce. I could actually go on and on about this particular one for another hour or two. This is very much happening in the United States with joint accreditation of continuing education, new models of experimentation in graduate medical education in practice is occurring. So we need people who know how to do this with interprofessional learning methodologies in practice today. The next reframe is from accreditation standards that focus on a single profession to incorporating the importance of team-based care. So old school thinking is that accreditation standards for individual professions have been actually viewed traditionally as barriers for interprofessional education. New school thinking, and is happening in the United States, is that accreditation standards require IPE and team-based competencies to move for more common frameworks for IPE and interprofessional collaborative practice across professions. Just a little bit about what's going on in North America. Canada has already addressed accreditation standards for interprofessional education. What's happening in the United States is the individual accreditors, and there are many, have actually written interprofessional collaboration in their accreditation standards. But like everything in the health professions, they never talk to each other. So we have a bunch of standards in medicine and nursing and pharmacy and the like that say this is important, but they never talk to each other. So over the past year and a half, the National Center has been working with 24 accreditation agencies to come together to facilitate a conversation. And we're very close to a consensus guidance document for interprofessional education for collaborative practice that'll be probably coming out after the first of the year. So 16 of the 24 accreditation agencies have already signed off on it. This is a historic event in the United States. And so we'll be able to roll up our sleeves and really have some very serious conversations about what should be required in universities and colleges along the lines of interprofessional education. As I tell our provost here at Minnesota, be expecting an accreditation site team to be here every year, many of them asking you about your IPE program. And then this is the last topic that I'll talk about with you today. Reframe number 6 is from a limited evidence base that interprofessional education benefits learners to a commitment to collecting evidence for interprofessional education and interprofessional collaborative practice, both on learning and health outcomes. So those of us who work in the field of IPE have been met with resistance to change because of perceived lack of evidence for both teams and IPE. So you'll go into a dean or you'll go into a president or a provost of a university, and the resistance has been, show me the evidence and then we'll change. Well, as you know, I've already alluded to the fact that it's hard to evaluate what you haven't done. But new school thinking, particularly with all of this massive change that I've described, is a real commitment to rigorous research methods in interprofessional education, leading to a growing evidence base that is used to redesign interprofessional practice and education to achieve, and this should actually be the quadruple aim. So again, I alluded to the fact that I know that best evidence medical education review, I point people to the Journal of Interprofessional Care. The impact factor of that journal has gone up significantly. Hugh will tell you, because he and I are working together as consulting editors, the number of papers that are coming in and the quality of papers that are coming into that journal are astounding. So again, the evidence base is coming, the commitment to research is definitely there. The last thing I'm going to just mention, because this is a whole nother topic, is that since getting the awards from the federal government here in the US and our private funders, we actually have been very committed to the research agenda for interprofessional education and collaborative practice. If you go to our website at nexusipe.org, under the tab that says Advancing, we make available our current research and thinking in the field. We're very close to coming out with an IPE core data set based upon data that we've been collecting across 70 sites in the US and 100 projects and programs. We are starting to understand standardized measures. And so we have the capability of collecting data in secure environments, de-identified data, that's building upon our national research network now. We will have, and we do have, an informatics-driven dashboard, and which will allow people to get access to their own data. And our long-range vision is that we'll actually be able to compare metrics and data so that approaches like realist evaluation or qualitative research, we'll be able to focus our efforts to where we need to be tending to in the research. So much more about this. It's obviously a very complex topic, but we're writing and writing about this area because we really believe that we have the capabilities to get the evidence, get the data that people are really looking for. And we're in this together. So more to be released on this particular topic. So I'm going to stop there. I'm looking at the clock and have some time if anybody has any questions. I'm very appreciative that I've been invited in September to the networks meeting. I've got it on my calendar. I would love to come. So I will stop there if any of you have any questions. And if I can hear you.
Well, thank you very much, Barbara, for sharing with us your presentation. And it really provides food for thought. And I think we need to really reflect on what we're doing and how we're doing it and how we can sort of refine what we're doing. So thank you very much for that talk. We're just going to give an opportunity now to any of the participants if they have any questions.
Anyone?
Okay, maybe I can start, Barbara.
All right.
Mabel, you have a question?
Okay.
No, from me, it was just a comment. Thank you very much, Barbara. This is encouraging for the people who are just beginning. But it is not impossible. But you touching on the old school, new school, the things that we look at, it is really assuring that, yes, if we look at interprofessional education, we can actually cut down a lot of unnecessary costs, including time, especially when I look at the issues of accreditations. Many people coming into one institution at different times, it's highly costly. It will be much cheaper if just one team comes to look at the whole institution. Thank you very much.
So the cost, let me just respond to that, because a lot of people get very, starting to talk about cutting costs or reducing costs or makes people very nervous, because often those decisions aren't made wisely. And so we also talk about cutting costs and adding value. And what we're not saying is that there shouldn't be investments. There absolutely should be investments. The issue is really taking a look at efficiencies, what makes more sense. And so it's more along those lines. And there's a lot in the cost factor that has to do with the United States system. And I'm very, very recognize that. And we have a lot to learn in the United States by reframing our thinking, particularly around community-based work and linking the community-based work with the health system.
Thank you.
Barbara, I like the concept that you bring in about retooling and retraining the existing workforce. In South Africa, we've looked at a postgraduate diploma in interprofessional education, which we hope to implement by 2020. And this is one method that we thought of bringing in the existing health professionals to come and sort of retool and retrain them. Do you have any other suggestions of what we should be doing?
Yes. That's a tricky, so my PhD is actually in this area of continuing education for the health professions. And I think about this a lot and actually want to do more writing on it. It's not about a curriculum. Like, you've got a curriculum and think people are going to come in and they're going to learn on your modules and they're going to go out and do well. It's really redesigning the instructional strategies in practice. So one of the areas that's really not well written about yet in interprofessional is workplace learning. I just adored this article by Gillian Nesbitt and her colleagues out of Australia. So I think as we think about this retraining and retooling, we're really moving the education into practice. It's much more of a reflective type of practice. Clearly, if we're asking people to change their roles, that's actually, we build people to think of themselves in a certain way. So the strategies for interprofessional learning needs to take on a different flavor. And again, this is an area I'm trying to write more about. Just to give you an example, I was meeting with some colleagues from Brazil when I was in New Zealand, and I brought up the name Paulo Freire, who is amazing writer on pedagogy of the oppressed. And I used to teach that I'm an administrator, I tell people back when I was a faculty member and I knew something, I think we need to go back to that kind of thinking and reframing and a very different approach to interprofessional work. And it's not that the modules and the like aren't worthy, we absolutely need them, but it needs to be coupled with a strategy, a different instructional design. Anything else?
Okay, thanks for that, Barbara. Colleagues, any other questions? And just bear in mind that you need to unmute yourself.
No, I don't have a question at this stage.
Okay.
Also, Penny here. Thank you very much, Barbara. It was really interesting, and I like it. And as more of an educator, although I'm not really involved at all in IPE, but it resonated a lot in other areas as I'm a nurse, and I think just the idea of ideal patient pathways. I like that a lot, and it helps me in my nursing practice even to think about how we nurse patients, never mind the interprofessional part of it. But I really, that really resonates, and I think it's a nice way of thinking about. And I like the idea of this ideal patient pathways by service, identifying the education that goes with that, the regulation and the practice changes that are needed. So yeah, thanks very much. That was great.
It's daunting, but it's nice that what I value about the New Zealand model is there was a leader who stuck his neck out. And I think we need to do more of that.
Yeah.
Hello.
Hi.
Hi, Barbara. I'm really excited with listening to your talk. Really, my work is around also nurse-led care in rheumatology.
I'm sorry, I missed that. What type of care?
Nurse-led care.
Rheumatology
nursing.
I could talk about that for a long time.
Yes. So yeah, really very interested about interprofessional education, but the issues around regulation and around traditional models of care, which are really is what we have across different countries in Europe and in Africa.
Right.
Yes, the training is wonderful, but how do you go about trying to change the culture and the structures and the systems that are already there, which are all professional based and not necessarily patient-based or personal-based.
So remember I talked about sticking my neck out? This is, so let me tell you about a project that I have going on in the United States. And, you know, in the United States, we have 50 states. Every state has their own scope of practice laws, their regulations. So it's not like we're talking about this, you know. And some of the states, I can show you a beautiful wheel with colors and where the states are that have progressive laws for nurse practitioner-led care and where they do not. So the project that I have gave grants to develop nurse practitioner-led teams in care in the community. And I have 16 sites. And this concept of the nexus is that you develop the university education with the community. We gave them just a relatively small amount of money and a lot of coaching. And I have an evaluation now that's going on. And I will be writing about this and the tools that are coming out of this. Some of the sites, I have 6 of them that are exemplary. And they are actually bringing physicians along because a lot of the care that needs to happen in the communities, most physicians realize they don't want to do that care, or they recognize that they may not be the best professional to do that kind of care. And I have many examples now. And so, for example, the exemplary sites we have a horrible addiction problem, opioid addiction problem in the United States, we're actually starting to demonstrate some very positive health outcomes when students come into teams. We train them in teams with a nurse practitioner-led team. And oh, by the way, the professions that are coming out that are the most important is actually occupational therapy and physical therapy. So again, this data, this talking about what the evidence is. Another example, I mean, we have now primary care clinics in low-income senior housing. Again, similar types of nurse-led clinics. My father in a memory care, I tell the physicians you wouldn't want to be captain of my dad's team because the nurse practitioner and her team came into my dad's apartment. They could see the environment, knew me as a caregiver, and they knew when the OT needed to come in or the social worker. The geriatrician came in every 6 to 8 weeks to just check on it, but it wasn't like day-to-day oversight. The cost savings to me and the care delivery system was astounding. So that's the kind, when I say, you know, these are the kinds of conversations we need to have. And absolutely, is there all sorts of tensions between the professions? Absolutely, and it's predictable.
Thank you.
Thank you for the question. Anything else? It's morning here, and I'll get my next cup of coffee after we're done.
Barbara,
not too early, though.
Barbara, you know, I share your sentiments that students are not going to change the healthcare system just through their enthusiasm, because our students are very enthusiastic. And then you also speak about modifying education. Could you just maybe comment on that? What kind of modification should we be considering?
So in terms of your curriculum and your students?
Yes.
Yeah. I don't know your curriculum and what you're doing, so it's really hard for me to give you a specific feedback. The part that I would recommend is to make sure there's a balance between what's taught in school, the classroom for practice, and what the students are getting in practice. And what is a very common issue is that we teach these collaboration skills in the classroom, and then students will go into practice and they're not seeing what we're teaching in the classroom. You know, teams and collaboration, and we all get along. And what I tell people now is, yeah, you're not going to change the system, so we need to inoculate the students and help them understand and reflect upon what they're seeing and why. So this issue of the tensions in the profession and the hierarchy is very real. So that absolutely needs to be spoken about. And somebody like Stefanis would be, you know, physicians are great facilitators of that conversation. So hitting that head on. And so therefore, I'm talking just about the students, but then you need to train the clinicians in practice. And how do you have those kinds of conversations? Who could be an opinion leader that is the particularly physician role model to have the conversations? So what I tell people is don't shy away from the tough issues. You know, how do we have a conversation about them? So an example back to that project that is a nurse-led teams, one of the best projects actually before they did anything brought in experts out of their law school in conflict resolution. So they actually taught the clinicians how to have those conversations and start to, you know, unpack what those issues are. So when I talk about Paulo Freire, that was his approach. So again, we're not there yet to the sophistication of that kind of thinking, because we're just starting to get there and realize, you know, that these kinds of conversations need to be had.
Hi, Barbara. Hi, it's Shweta. I just want to come in here with some, I think what you're raising is is really, is very, very relevant to our situation here in South Africa. I'm from the same university that Gerard is from. In fact, the issues that you raise is what we are actually grappling with in terms of looking at designing IPE programs based on the needs of our communities and our patients. And in fact, for the last 2 days, last week, for 2 days, we've been sitting with grappling around how do we actually design this program for our final year students. And we basically came up with a model where we're going to place our students within the projects that are currently existing in communities and placing students, teams of students in these projects based on their needs. So I think so what I'm hearing and what I'm excited about is the fact that it resonates very much with what you are advocating in terms of your presentation, in terms of your thinking. But I also like the fact that you are, the framework that you are using, Paulo Freire's framework, which I have used as my framework for the service learning module that I use for second years in my health promotion module, which is also kind of a community-based interprofessional module, where the framework is so much applicable. We are integrating it in this particular interprofessional module, looking at the issues around conscientization, dialoguing and praxis, which is part of the Paulo Freire's framework, that when we take students in these communities, we need to enter into dialogue with communities, with the teachers, with the educators, and through this, and it's a way of also conscientizing our students around the issues of the needs of the community, and then developing collaborative, practice or interventions. So I really want to thank you for this, because I think, and it's sharing kind of it contributes to our thinking around how do we actually design programs, and I'm definitely going to look at the website that you've alluded to and some of the readings. So thank you for that.
Oh, good. The one comment, and you were coming in and out a little, so I hope I caught the essence of what you were saying. The one thing I want, so my whole career has been at the edge of universities, like big time research universities, looking out, and how do you engage communities in. And what I find is there's so much good work going on in the communities, and how do we value and take those value systems and flip it so that we're actually having a better dialogue with the universities. So again, that's where my passion is. I don't know if you could tell it. And so I really do want to come to your meeting in September and learn from you.
Thank you.
Thanks so much, Barbara.
Thank you.
Colleagues, any last minute questions? If not, then a huge thank you for your time, Barbara.
Thank you.
Really appreciate it, and we look forward to seeing you in September if everything goes well.
Okay, sounds good.
And with that, thank you to all the other colleagues who took time out of your schedules to join us. We really appreciate it. We will be having our next webinar in about 3 months' time, where we've invited John Gilbert. So please look out for that one. We will send correspondence around that. And with that, thank you and have a good day further.
Thank you.
Thank you, Gerard. Thank you, everyone. Goodbye.
Bye.
Thank you, everyone. Bye.
Bye.